Hi, everyone, and welcome to our webinar today. I'm Jen Elder. I'm the director of the Homeless and Housing Resource Center, and we're excited for you to join us today to talk about funding supportive housing services for people with behavioral health needs. Next slide. So before we get started, we have a quick disclaimer. We are funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily represent official opinions or views by SAMHSA or HHS. So next slide. We do have American Sign Language interpretation and transcription with us today, as we do with all of our events. If you have any technical difficulties during the webinar, please feel free to reach out via the Q&A feature or via our email address, and we will try to troubleshoot as best we can. So a couple of housekeeping items before we get started. We are excited to be joined by so many people today. So all the participant lines are muted and the chat feature is disabled. But that said, please be encouraged throughout the webinar today to submit your questions using the Q&A feature. As a reminder, and we'll share it again at the end, we are going to have an office hours next week to help follow up on those questions. So if we can't get to all the questions today, know that there's a session next week dedicated just to the office hours. The slides are available now. There is a lot of great information about funding being shared today. So if you want to go ahead and head over and download those slides real quick, we've got the link in the chat to follow along. That could be helpful. We'll have a recording on our website available in about 1 week. And we do have a new process with this webinar for our evaluation. If you've joined us before, it's slightly different. It's a shorter evaluation, but it does still come with a certificate of participation. So we'll be sure to share that link and QR code with you at the end of today's webinar. And again, reach out to us if you're having any trouble accessing that certificate. So next slide. So without further ado, we are so excited to be joined by Rachel Post and Sherry Lurch from the Technical Assistance Collaborative, and I'm going to hand it over to Rachel to get us started. Thanks so much.
Great, thank you so much, Jen. Really excited to be here and talking with folks today with my colleague Sherry Lurch, who's the director at the Technical Assistance Collaborative, who I get the pleasure of working with. Go ahead and move to the next slide, please. So today's topic is funding supportive housing services for people with behavioral health needs, key federal resources. And you'll see here the agenda. And so, we're going to cover each of these items in this order. We have about an hour. We hope to allow for close to 10 minutes for questions and answers at the end of the presentation. And if you would like to go ahead and advance to the next slide, that'd be great. So we have a couple of poll questions because we just really want to get a sense of the folks who are here today. So if you can bring up the poll and have folks click on what your current role is, that will give Sherry and me a better sense of who's here today. We usually take about close to 30 seconds, and then we'll be able to see the results of that. All right, so it looks like about 30% of you are direct service care coordinators, 22% are program managers, we have just a few funders, we have a few grant writers, some benefit specialists, and then others. So great. Thank you so much. And then we have just one more quick poll question. So what federal resources do you use to cover supportive housing services? So you have, you can select, I think, multiple options here. So we've got, I don't know, we don't currently use federal resources to cover services, Medicaid, SAMHSA grants, the HUD continuum of care, or other. Just give that a minute. All right, so looks like about 11% of folks aren't quite sure. We've got 16% who say they're not using federal resources, 10% are using Medicaid, 6% are using SAMHSA grants, 40% are using HUD continuum of care, and then 16% identified other. So thank you all so much for taking the time to go through that. Let's go ahead and move on. So just to kind of frame the discussion for today, I think most folks who are joining probably already understand the impact that supportive housing has on health and housing outcomes. So we have a couple of different graphics here to really just illustrate that. And this is to really help, set up the discussion about why it is so important to identify the resources that can fund supportive housing services. So we know that people who are coming out of hospitals need a place to live, people who are unsheltered, people who are in the emergency rooms, and that there are multiple studies that have documented the efficacy of supportive housing in reducing emergency department visits, residential substance abuse treatment, hospital inpatient admissions, and nursing home use. And you can see here on the left that researchers also observed average annual cost savings of $6,300, with greater average savings among chronically homeless and among those living with HIV and AIDS. And to the right of that, you can see a different graphic that shows the potential savings. So we know that these services are incredibly important. I also just want to emphasize that we know that the level of service and the location of services is also significant. So we know that these outcomes are generated when we see evidence-based practices of supportive housing being delivered, where there are low client to staff ratios, where services are delivered in the community, where there is 24/7 crisis response capability. So with that, I want to move to the next slide and just highlight that the Homeless and Housing Resource Center just released this document, Funding Supportive Housing Services for People with Behavioral Health Needs, and that is available to y'all, and that today's presentation is really drawn from that resource that both Sherry and I had the privilege to develop for the Homeless and Housing Resource Center. So with that, I would love to turn it over to my colleague Sherry Lurch, and she's going to talk to us more about the funding needs and resources.
Thank you, Rachel. Good afternoon, everyone. It is my pleasure to be part of this webinar. There is a pretty large group of participants, as we saw from some of the poll questions today, and I'm sure that there are varying degrees of familiarity and understanding of some of the content we are going to review today. I would encourage you, if we're trying to sort of hit the middle of the mark here, if it seems like the information is not detailed enough, or if the information is really maybe perhaps more complicated than what you're able to take in today, that the office hours will be an opportunity for you to gain a better understanding of the information, as well as we can do a deeper dive into specific questions, if that will be helpful for some of you. So again, today's an overview, lots of information. I certainly would encourage you to review the document as well as download the slides. There are links to several resources we will talk about today that will provide you with additional information. So let's talk a little bit about, understanding funding needs. We know that no one funding stream covers all of the covers high quality supportive services that individuals may need to live in independent settings. That braiding various sources of funding, including federal, state, and local funding, is required. And we'll go through what many of these options are. We encourage you to work with your behavioral health authority, the HUD Continuum of Care, and the state Medicaid authority to identify current availability of supportive services and identify gaps that may exist. Medicaid, and we're going to review Medicaid in more depth here shortly, but it has become an increasingly important funding stream for housing-related services and supports across the country. Several states have received approval of Medicaid waivers and state plan amendments to cover these services for people who are receiving Medicaid. And other states are using other Medicaid authorities, such as some existing services you may have heard of, like targeted case management or psychiatric rehabilitation, peer support, to provide a package of services and supports. Identifying the services and supports that do exist and understanding their basics is really critical to then being able to understand and identify what the gaps in services and supports are, so that resources can be targeted and interventions can be identified to fill those gaps. Next slide. So let's talk a little bit about Medicaid. Medicaid is an authority through the Federal Centers for Medicare and Medicaid Services. It can cover many, but not all of the services and supports that people, particularly with behavioral health needs, may want and need to live in the community. We know through Medicaid expansion that a number of states, in fact, as of February 2022, 38 states and the District of Columbia adopted Medicaid expansion, which made coverage available for a much larger population of people experiencing homelessness who could then be Medicaid eligible. So it's really critical, again, that you understand what Medicaid can and does cover in your state, but it's also important to understand that benefits do vary from state to state. And it can be part of what's frustrating when you hear about what one state can do, but that's not available in your state. All states must provide coverage for certain services. They're mandatory services, but there are also a lot of options that states have to add to their state plan, as well as to pursue something called a Medicaid waiver authority. And we'll talk a little more about those here in a little while, that can cover additional services and supports. In general, though, Medicaid does provide the most comprehensive coverage for medical, mental health, and substance use disorder services for people with disabilities. It's helpful to determine if individuals are or were ever covered or eligible for Medicaid, and to assist people to apply or reapply if they are no longer eligible or if they've lost eligibility, to help them to have access to this broad array of services and supports, including housing-related supports. Next slide. So we're going to just very briefly review what Medicaid, the Center for Medicare and Medicaid Services, defines as the services that can potentially be covered under Medicaid. And I did say potentially. Pre-tenancy services are those services that assist individuals to prepare for and to transition and move into housing. And here we have several examples of what pre-tenancy services can include: assisting with locating housing and amenities within the area to promote community tenure, determining safety and quality of the housing unit prior to the move-in. It can include providing assistance in completing an application for housing assistance, things that many of you probably already do, reviewing and signing a lease or a rental agreement. I'm sure these activities are very familiar to this audience. Next slide. And then when we talk about tenancy sustaining services, these are the services that, once a person is housed, promote their housing tenure, their ability to remain in that housing and to be successful, to live in a stable setting. Such things as providing services and intervene with behaviors that may jeopardize housing, such as lease violations, education or training on the roles, rights, and responsibilities of the tenant and landlord, etc. To ensure that these services and supports are effective, programs must be able to individualize them. And you'll hear about that again as we talk about some of the options moving forward. To be successful, it's got to meet that person's needs and interests. Should be based on an assessment of their strengths and interests. Effective programs must be well-versed in engagement strategies that use evidence-based interventions, such as motivational interviewing and trauma-informed care. Again, approaches that I know you are familiar with. We want to be sure that people stay into services rather than voluntarily elect out of services. And they need to be adjustable to meet the tenant's changing needs over time. We know that working with people with lived experience or providers of what we call peer support are very effective. It's an effective strategy in gaining voluntary participation in these services and helping them to have maximum impact. Next slide. When we talk about Medicaid authorities, it can seem like a very complicated topic. So I'm going to provide an overview of just a couple, and I want to be, again, help you to understand this is very high level. I encourage you, obviously, to read the resource document, to download the slides for additional detail. These are two that we are highlighting today, but there are others as well. So states do use different options for providing some or all of these housing-related services and supports. Sometimes the choice is really based on what their existing service array may cover, as well as goals and objectives of their Medicaid program going forward. We're going to start with something called a state plan authority. And 1915I is a state plan authority. The importance of that for all of you is that it means that services are an entitlement, that there can't be a limit on the number of people who receive the services. But if someone meets the eligibility criteria, they're enrolled in Medicaid, they go to a provider that's a Medicaid enrolled provider for the service is to be made available. With the 1915I, it's also important to understand that services covered under this benefit, individuals don't need to meet criteria for what we refer to as an institutional level of care, meaning they don't have to be eligible, say, for a nursing home, a nursing facility, in order to be able to receive the service. They do, though, need to meet the eligibility criteria as identified by the state, and states have flexibility in what that eligibility criteria may entail. This covered authority also requires that there be what we call a non-biased assessment, meaning that an individual assessment is conducted by an entity that doesn't then provide housing-related services and supports. So that's an important distinction for this. We also offer a state example, certainly the services that can be covered and a state example. And in this case, we've featured Minnesota. Minnesota is well known nationally for implementing the 1915I to cover housing-related services and supports. It is a tricky authority to implement, states would tell you, but Minnesota seems to be moving full speed ahead and doing a nice job with including the housing supports through this Medicaid authority. Next slide. Another example we wanted to showcase today is a waiver authority. Unlike a state plan amendment, waivers can limit. They can limit the number of people that the waiver covers, and states often do. An 1115 authority is a demonstration waiver. What that means is it allows states to test approaches and coverage. Many states are using the 1115 waiver authority to test coverage for services that address what we call, and you all I'm sure have heard the term, social determinants of health, including housing stability. This waiver authority provides a lot of flexibility, and states are determining if covering housing-related services and supports for Medicaid recipients impacts their utilization of more costly Medicaid services that are part of the state Medicaid plan, services such as inpatient stays and emergency department visits. The 1115 authority also allows states to use alternative payment approaches for services. So for those of you who are familiar with Medicaid through fee-for-service, you know a provider gets paid for each widget of service that they provide. With an alternative payment arrangement, there can be a daily payment or even a weekly or a monthly payment that's made to a provider, which helps to cover a broad array, in this example, of housing-related services and supports without billing for each widget of service at a time. We also see with many states that under this authority, they are utilizing capitated managed care. And we'll talk a little more about managed care here shortly. The full array of pre-tenancy and tenancy sustaining services as described in those earlier definitions can be covered under the 1115 demonstration waiver. And the state that we are using as an example here is Washington State. They provide something called foundational community supports that include this very broad array. In addition to eligibility that includes age and functional impairment to be eligible for this benefit, they also identify that recipients or eligible folks must have at least one risk factor, and that risk factor includes chronic homelessness. So clearly the population that you all serve and interface with in Washington State could and would likely be potentially eligible for benefits under this authority. Now, not all 1915I or 1115 waivers are the same. Each state, again, has lots of flexibility in how they design and submit their applications to the federal government. So it's really important for you all to know and understand if your state uses one of these authorities, specifically what it is that they cover. They may even use other authorities through Medicaid or cover a wide array of services through the state plan, which is why learning what your state does cover is really important. And when you download the slides, you will see under this slide, the Find Your State Profile. If you click on that link, you will be able to find the various authorities, Medicaid authorities that your state has in place and what those authorities cover. Next slide. In addition to understanding what your states cover, the benefits that they provide, it's also important to understand how Medicaid is administered for those benefits. Many years ago, the state agency oversaw directly the benefits that were provided and enrolled providers directly. But more and more states have expanded coverage for services and target populations. Many states have moved into contracting with administrative entities to manage these benefits. 40 states and the District of Columbia, as of July of 2021, were contracting with managed care organizations to administer benefits, while 9 states were operating Medicaid ACOs as of the spring of 2022. ACOs, accountable care organizations, are different in that managed care entities tend to be administrative. They contract with provider networks to deliver services. They oftentimes credential and enroll those providers. They conduct medical necessity, and they produce authorizations for services. Now, managed care organizations may have a national footprint. There are large companies that operate all across the country, and there are oftentimes locally grown managed care organizations as well. In many states, they are responsible for identifying housing needs. And in some states, they are even incentivized, where they receive an incentive, a performance incentive payment to assist people in gaining and remaining stably housed. Accountable care organizations are part of the healthcare system. They are large medical healthcare providers. They also then contract or subcontract with other providers and agencies to deliver a more comprehensive array of services and supports. And they too are interested in keeping their members stably housed to improve their use of primary routine care and reducing their need for sporadic emergency medical and behavioral health care, which again, these tend to be more expensive, they're highly intrusive for members, and they don't necessarily promote ongoing stability. Understanding the difference, again, I realize this might be providing a lot of information, but again, I would encourage you to read the document for additional background and level of detail. Next slide. So in addition to Medicaid, we're going to pivot and shift our attention to non-Medicaid resources. Again, I said earlier, Medicaid provides, a large amount of funding for both medical as well as behavioral health, but it's not the only funding source. For people who are not eligible for Medicaid or prior to their being enrolled in Medicaid, these funding sources are extremely critical. There also will be services that Medicaid doesn't cover, and these services can help to fill in those gaps. We refer to behavioral health authorities here in our presentation. In your state, they may be referred to as the mental health office or division, or the substance use disorder office or division. That's who we are referring to when we say behavioral health authority. They are responsible for administering resources to fund services not covered by Medicaid, and they typically are involved in establishing policy and may also administer the funds, the dollars that are available through your federal block grants that states receive, as well as states may allocate a portion of tax revenue, just about every state does, to also provide a safety net of services and supports that Medicaid may not be covering. The block grants through the Substance Abuse and Mental Health Service Administration, both the Community Mental Health Services Block Grant and the Substance Abuse Treatment and Prevention Block Grants, are sources that can help to fill in some of the gaps that Medicaid might not cover. And again, you'll see when you download the slides, there are links that both identify what your state block grant awards, the amounts that they are, as well as then how you can use those grant programs to also fund supportive housing services for people with behavioral health needs. Let's go to the next slide, please. There is considerable overlap between the services that can be covered by Medicaid, as we discussed earlier in the SAMHSA or Medicaid, CMS approved Medicaid definitions, as well as the SAMHSA definitions of what can be covered or what is essential to provide, the services essential to provide to people to help them to access and remain stably housed. One of the important differences that SAMHSA identifies and that is not often covered under Medicaid are the outreach, engagement, and referral services. Outreach is considered, identifying individuals who may be eligible and certainly then referring them to apply for the benefit. So until that time, some of these other funding sources are necessary because the person may not yet be enrolled in Medicaid and may not, be determined to be eligible, but you don't know that until you actually do that application. So that's a really critical service when you're thinking about how do we cover that. States have started to use a couple different avenues as well. Georgia has been able to use administrative funds to help to outreach to folks and cover that through Medicaid. But they're one of the few states that I'm at least aware of that have been able to do that. So it is just one of the areas to keep in mind where you may need to devote some other resources other than Medicaid. Next slide. Again, housing stabilization and ongoing tenancy supports and wraparound services, very consistent and, all in line with what Medicaid will pay for, but other service sources can also be used to pay for these as well. Next slide. So if we have these various funding streams, and we know that resources need to be braided together in order to maximize the dollars that are available, we need to focus on building partnerships between the agencies and entities that administer these various resources. To be most effective and efficient, they must be coordinated at the state, at the local, and at recipient levels. We need to have state agencies coming together and working together to understand how their various funding sources can be brought to bear to support a cohort of individuals. And locally then how they're administered to be braided together for the benefit of individuals to be served. And then for individual recipients, based on those individualized needs and interests that we talked about earlier, what are the various funding streams that can be brought together, woven together to support each and every person? And it will vary. It will vary from person to person. It requires very intentional partnerships. These things don't just happen magically. And for those of you that have been involved in bringing partnerships together, it can be hard work, and it can take a lot of ongoing negotiation and collaboration and supporting each other. It's really, a commitment at all of these different levels. But the commitment has been made pretty clear at the federal level. And it's why we really are encouraging and working with states and local entities and all of you to also bring your partnerships to the table, or come to the table to establish these partnerships to help benefit individuals who need all of the resources to come together for the optimum outcomes. To incentivize collaboration, there are a couple levers that you all, I'm sure, are aware of, and if not, you should be aware of. The systems that administer these resources that we've covered earlier, the funding sources, are responsible for the maintenance of the health and behavioral health of the population that they serve. And providers can reduce healthcare spending substantially when they connect people to services that address their housing needs. Rachel reviewed some great data along those lines. So as a provider, you bring valuable capacity to systems responsible for improving health and reducing the cost of care. Next slide. Homeless service providers bring a lot of experience and expertise in outreaching to and engaging individuals who would benefit from stable housing and services and supports. If your state Medicaid program and behavioral health agency covers already the array, or at least many, housing-related services and supports, your agency may want to pursue enrolling as a Medicaid provider or a provider within the behavioral health system, so that you can help to lend that expertise and experience that you bring into outreach, engaging, and then stably supporting people on an ongoing basis in their housing. But I would say this, It requires a great amount of administrative capacity. As we used to say when I worked for our state agency, Medicaid is not for the faint of heart. You have to determine whether you have capacity within your agency to integrate these funds into your supportive housing program. You can consult with your state Medicaid and or behavioral health authority. You also, if there are managed care organizations or accountable care organizations, as I said earlier, in many states there are, they also will outreach and provide a lot of support and technical assistance to enrolled providers that deliver benefits that they are very interested in expanding in their networks. So there is technical assistance, there is consultation available as an agency to help you if you are interested in moving in that direction. But if you are not either enrolled in Medicaid or don't feel like you have the capacity to enroll directly on your own, many states also allow agencies to partner with another provider that is enrolled in Medicaid, and that can help to orient, you can help them to orient them to the benefits of such a partnership, like how your expertise and experience can help them to achieve better optimal health outcomes, behavioral health outcomes for the people they're serving. Potential partners that are enrolled in as Medicaid providers could be federally qualified health centers, hospital systems. Again, as I mentioned, a lot of times, they can be financially penalized when there are readmissions to some of their services. So if you can help them keep people stably housed and reduce those admissions, they may be very interested in partnering. And then community, we have mental health here, but it could be, mental health and or substance use disorder agencies who also want to access housing resources for the people they serve so that they have better outcomes as well. These are organizations that already have the billing processes set up. They know the codes, they have the staff to do that, to process the authorizations, et cetera, and then you all can just deliver the service. And I don't mean just in a minimalistic way. It's the important role that you can play as a partner. Next slide. In the event that your state doesn't cover these services, perhaps there are lots of reasons why states haven't gone down these paths yet. And if they don't cover the array of housing-related services and supports, you can help to advocate for filling gaps by a number of different options that we have available here, we've identified. Most behavioral health authorities, they have flexibility in how their block grants, both their mental health and substance use disorder block grants, are used. And they are required to include stakeholder input into their plans that are submitted to SAMHSA for approval. Many times they have public notices about opportunities for people to submit comments. And by submitting public comments about gaps in housing and housing-related services and supports, you can have an impact on how those grants, those block grants, are utilized in your state. You can also make the business case, help to make the business case on how housing-related services and supports will improve either the behavioral health authority or the state Medicaid plan's outcomes. It's a very useful engagement strategy. You can provide data on how your services impact the health and well-being of individuals that you serve who are also served by the Medicaid program or the behavioral health authority. And you'll see we also offer this particular resource when you click on this publication for more information on how to gather system partners, to advocate with Medicaid and other healthcare systems to include the array of services and supports that you all know are critical to helping people access and live in stable housing. Next slide. As one last opportunity for states who may not cover housing-related services and supports as an entitlement, again, under their Medicaid state plan. States will often allow their managed care organizations and even accountable care organizations to cover services that can reduce healthcare costs for their members and yield better outcomes. By partnering with these entities through partnerships, those funds can oftentimes be used to pay for non-Medicaid eligible housing-related services and supports. Also, there are state general funds. Oftentimes there are county or local funds or other public and private funding sources that can fill gaps in coverage. So whether it's partnering with your local behavioral health, mental health, substance use disorder agency, sometimes reaching out to philanthropy can be extremely fruitful. They will have funds that they are willing to allocate to also fill gaps in the safety net, and local authorities may do that as well, so that they can help to keep people stably housed and have better outcomes for the individuals as well as for the community. So I got through that a lot more quickly than I thought I would. I am going to turn it back over to Rachel, and I think she will be facilitating some questions and answers, or may have additional information to share. Rachel?
Yeah, great. Thank you so much, Sherry. I always learn something new, even though I've been sort of working with you and other colleagues of mine in this arena for a few years. I feel like each time I hear it, it sinks in a little deeper. So, you know, some of the themes of questions that we've had relate to, you know, questions about, well, how, if I'm like a provider, but I am not a Medicaid provider, like, how do I develop that partnership and what does it look like? And, you know, you talked about that. We have some sort of high level tips, and I think in the brief, a little bit more descriptive, but I just want to, you know, echo what Sherry said earlier, is this takes time, and it takes a lot of intention and outreach with partners. So with FQHCs or community mental health agencies that are already Medicaid providers, sometimes with states, if we're talking about looking at Medicaid authorities that can cover this. It's not something that typically a frontline service provider is going to do, or is a part of your job description, or possibly not even something that a program manager might necessarily be engaged in. But really raising that to your executive leadership committee, bringing it to the HUD continuum of care governing body. You know, if you're part of the homeless service system, for like, why don't we have these partners on our governing board? What can we be doing to bring these additional resources to support folks with housing and services? So, you know, this is a complicated effort, and I just wanted to echo, you know, that, and it's not something that, you know, can necessarily be done very, very quickly. That said, Sherry, one question we had came up related to, for folks who are incarcerated and, you know, when they're discharged, you know, they don't necessarily have quick access to housing and services. And, you know, they aren't on Medicaid while they're incarcerated. And so any best practices that you're aware of to help folks with in-reach programming, so that when they come out, they are immediately enrolled into Medicaid and connected with HUD continuum of care or other housing resources?
It's a great question, and it's an area that states continue to, I think, press in. There are states who would really welcome, excuse me, and I believe have actually submitted requests to CMS for Medicaid coverage for a very brief period of time to start that relationship with InReach. I will do some background checking between now and office hours to identify some states in which perhaps they've made some progress in this area, perhaps through an 1115 waiver. I do know a number of states that have also targeted state dollars and resources to reentry efforts to conduct that InReach and to really establish those relationships before the person leaves. A number of states have done what they call suspend Medicaid eligibility while a person is incarcerated. So rather than completely end it when the person goes into a justice setting, criminal justice setting, they temporarily turn the eligibility off, but the date upon readmission to the community, reentry to the community, they are then able to turn eligibility back on rather than have to go through the whole reapplication process. That expedites eligibility a lot. And I think a lot of states have found great success with that. But again, I'll check to see what other examples of reentry I can find that may be of interest to all of you.
Great, thank you so much. And then another individual asked, is funding for supportive services available to those that have felony convictions? And you know, once a person has completed their time and they're returning to the community, I believe this is correct, Sherry, there's nothing that prohibits them for being eligible for Medicaid once they're released. Is that correct?
I'm not aware of any disqualifying criteria based on a past conviction. Medicaid is really around disability, means testing, those kinds of things.
Yeah, thank you. And let's see, so we have a question from Latasha. Can a state harm reduction center partner with a continuum of care to close the gaps in housing resource services? And I would say absolutely. I think any resource, any center that is delivering services to this really vulnerable population of people who need housing and support services can partner with the HUD continuum of care. I know that substance use disorders are, you know, that a significant number of individuals experiencing homelessness, and particularly chronic homelessness, experience substance use disorders. And anything that a harm reduction center has to offer in the way of partnership with a COC and the providers, absolutely that would be beneficial. And so I think we have a question from Kirsten and Jennifer, just related to if a partnership with an FQHC or a community mental health agency were to be explored, would that consist of that Medicaid covered agency delivering the supportive services to their in partnership with this agency, or could the Medicaid covered agency contract with the housing support service provider to deliver those Medicaid covered services?
I would suggest it can be very technical, and I'll try not to be. It really depends on your state rules. There are states that allow a federally qualified health center to partner with another entity. There are other states that would require a subcontract for that entity to actually deliver the service and provide the service, but the federally qualified health center to do the billing. So the FQHC wouldn't actually provide it. They would subcontract with the agency to provide the housing related services and supports. But it's really important to consult with, and the FQHC would know that if they, you know, would be a partner, what your state Medicaid program will allow.
Great, thank you. So we have a question from Anna related to what qualifies as permanent supportive housing. And so for that question, I would direct you to, and maybe Amy can include this in the chat, the link to, we developed the Housing and Homeless Resource Center developed, I think it's about a 4-hour training curriculum on supportive housing that they have available on their website. It was made available last year. And we have encouraged folks to go through that training because it's got some really just great information, and for newer providers, some foundational information about supportive housing. And I see that Amy did just include that in there. So, Anne, I think I would direct you to that training for your, I'm sorry, Anna, for your question. And so Abby asks if coverage for representative payee services is included in housing related support services, and just recognizes the value of represent payee services. So Sherry, I don't know if you have a quick answer for that one.
I would say I am not aware of too many authorities, Medicaid authorities, that would include representative payeeship as a covered Medicaid expense. That doesn't mean there aren't any out there. I wouldn't want to swear to it, but I would say that is a service, a role that I'm not at least familiar with. Now, again, if others are, please chime in, and I will certainly do some research between now and office hours to provide further clarification if I can find any.
Great, thank you. So here we have a question from Kirsten. I work with people who actively use drugs, who often struggle to qualify for and remain in stable housing. At what level are housing first criteria, housing regardless of current substance use described and enforced? Is that connected to the funding source, SAMHSA or Medicaid, or determined at the local continuum of care level? It's not really a Medicaid issue. SAMHSA, if it is, it's really more about attending to evidence-based practices. And again, I would highly recommend that 4-hour training curriculum for you, Kirsten, because I think that could be really helpful. Let's see. All right. Problem in Hawaii is we don't have homes for severe autism with behaviors. No facilities, either they're shipped to their loved ones on the mainland or put them in housing or any facilities, but these facilities house 21-year-old, then they send the young adult back home. I'm trying to figure out how to get more services for these gaps for these kids. So Sherry, I don't know if you have any insights there.
Services to youth under the age of 21. If our colleague Diana Simmons was on the webinar, I believe she would say that early periodic screening, diagnosis, and treatment is an avenue for states to cover medically necessary services for youth up to age 21. Unfortunately, I don't believe states fully pursue and exhaust that opportunity. Youth and children under the age of 21 can also be covered under various waiver authorities for autism spectrum disorder that could help to provide additional services and supports, but your state would have to pursue one of those waiver authorities. It is more beneficial, obviously, to the child and youth and family, and less costly if the youth is to the point where they would need some type of, quote, institutional placement in an intermediate care facility, or some type of Medicaid reimbursed congregate care provider. If they are living with their family, though, you would need to have those community-based services through the other opportunities I just referenced.
Thank you, Sherry. And then I just want to call out that I think it's Ree. I'm not sure if I'm pronouncing your name correctly. Just wanted to note that Hawaii Medicaid does cover supportive housing efforts, and that it's been great. So thank you for sharing that. Someone asked, is there any gap in Medicaid eligibility for those jailed for an extended period of time but not convicted? So.
Oh, now you're testing some of my, I will research some of that. There is language about under the, I want to say the authority or jurisdiction of the court. Let me look into that a little bit further. I don't want to give you misinformation. So let me see what I can find out there.
Great, thanks, Sherry. And then Lilia, I'm so sorry if I'm not pronouncing your name correctly, is just asking about if a local entity is considering partnering with other entities, are there SAMHSA and HUD standards that should be considered in the planning, standards regarding service provision? And what I would say to you is that your partners who are administering SAMHSA grants and HUD grants will know what the standards are. So that's something that can just be included in your conversations. They'll know, you know, what they're able to use those funds for, what the conditions are related to that. And another person talks about just that folks with felony convictions may find it very challenging to locate housing in the community, and how to help navigate this. So I really think this is, there's some really innovative practices in different communities around the country on how to do this. In my own personal experience, having worked at two large homeless service provider agencies that owned affordable housing stock, that they were able to, you know, when folks were engaged in services, they had maybe less restrictive requirements related to folks who had histories of eviction or poor credit or felony convictions. Obviously, there are a couple of criminal convictions that ban you from accessing federal HUD-funded federal housing, and I believe that's arson, and then a federally recognized sex offense. But short of that, and possibly methamphetamine production. Short of those, I think that there are a lot of communities that are working very closely with folks with felony histories to help support them in accessing housing with landlords or organizations that own properties that are sympathetic to the population and attached to services. Okay, so and while folks we're looking at these questions, you'll see here on the screen that Jen referenced earlier, this evaluation and certificate of participation. And if you can click on this link or take a photo of this little, I'm sorry, I don't know the technical language of it, you should be able to see that up on your screen. And I also just want to remind folks that, thank you, Amy, QR code kind of ages me, that we do have an office hour on, maybe if you want to go to that next slide, you'll see here on July 7th. And the registration link, I'm pretty sure Amy will copy that into the chat if she hasn't already, that you can submit questions in advance so that Sherry and I can prepare to be able to answer your questions. And so certainly encourage folks to take advantage of this office hour time, especially folks whose questions we didn't have time to get to today. Someone asks, I was more thinking, about housing funding. Sorry, I'm not sure which one that's in reference to. So I think we'll probably pause there. Jen, I do not recall, would you like to say a few words to kind of close us out?
Yeah, just I mean, thank you so much. There was so much information shared today. So just a reminder, go find those slides, download them, review it between now and next week, and bring all of your great questions to the office hours. We've got those links in the chat for how to register. So thank you everyone for your time. Appreciate it. And we hope we see you at future events and at the office hours next week. Thank you so much, Rachel and Sherry. All right, take care.